Hi, and welcome to this month's webinar. Um, we're going to be looking at biomechanical dysfunction movement states, their assessment and their treatments. And we're going to concentrate on process rather than the details of the techniques. I find that most people get caught up on the detail and really lose sight of the bigger picture. And it's a process that gives you a better understanding of what you're trying to achieve with your assessment and treatments. So we're going to ignore the techniques. And I think probably of all the things that we do, technique that you select to do anything is among the least important ones. Techniques go through an evolutionary process and they work because they've been found to work over time. So almost any of the older techniques, not so much newer ones necessarily, but the techniques that have been around for a while are working because they have been found to work. The reason I select the techniques that I do is simply that there's a rationale for them, and it's based on the biomechanical dysfunction, and that helps you produce a model of the problem that you're dealing with. And models are important. They don't have to be true, but they do have to explain observations and facts. So this is where we're going with this. It is about process. So I hope you enjoy it. I hope it gives you something that you may not have had before, or a better understanding of stuff that you did know before. So let's get on with it. But first, the quiz. Here are two faces, the gentleman looking surprised and the lady looking enigmatic. Are there pathologies present, and if so, what are they? I'll give you another 5 seconds to just glance at them and see what you think. Okay. Should do it. Okay, let's get some background on this, and we'll look at, as we say, we're looking at biomechanical dysfunctional motion states. And we'll come up with some operational definitions that will allow you to determine what they are from your clinical exam. So basically, if we really divide these into big groups, it's hypomobility, hypermobility, instability. Now obviously there are different types of hypomobility outside of biomechanical dysfunctions, including bone effusions, infectious arthroses and all the rest of this stuff, but we're really just interested in these biomechanical ones for the moment. So hypomobility. Range of motion limitation can be caused either by a problem with the joint, the major ligaments of the joint and the joint capsule, swelling inside the joint and so on, but it's an articular problem. Or it can be caused by something that's outside of the capsule, mostly the muscle. The muscle is either scarred, contracted, adherent, or hypertonic. So we have these two things we have to consider. Now, as far as articular hypomobility is concerned, the pericapsular one is the one that we're obviously most familiar with. Outside of biomechanics, within biomechanics, I don't think that's true, but outside of biomechanics, it certainly is. We're looking at contractures in the joint capsules, fibrosis, arthrosis, that's led to the joint capsule becoming contracted, or you can have damage to the capsule where it scars or becomes adherent after something like infectious arthritis in particular, where we get a lot of exudate within the joint, and that allows adhesions to form. So we have pericapsular restrictions. We have arthritic conditions as well, where the joint's actually inflamed, and the limitation then is both within the joint by the actual volume of fluid within there, but probably more importantly by pain and the effect of pain on muscle. So spasm would limit this. And while we could consider the spasm to be extra-articular, basically it isn't. It's still the joint that's causing the problem. So if we look at diagnosing and then finally there is a pathomechanical restriction, which is not well defined at all. There are a number of opinions of what it may be, including inclusions in the joint and so on. As a simple model though, which is really all we need for this, we can think of the joint being stuck at one end of its range, not by structural problems as such, that is, there's no adhesions or anything like that, but there's an underlying instability of the joint that allows the facets, for example, the joint surfaces, we look at a facet which should be sliding up and down, to wander off to one side and then get caught. In this case, it's caught in flexion. So if you push it further into flexion, you get a fairly normal end feel. It might be a bit softer than you would expect, but it's reasonably normal. When you try and take it out of flexion is when it actually jams up. And while there's nothing structural holding this, it is still stuck there. Now, this can be manipulated, and a single manipulation can give you an increased range of motion to normal or even excessive range, because there is more movement into flexion where the instability laid. So this obviously can't be adhesions limiting the joint. Now, in all three cases, actually, the joint glide will be affected because it's an arthrotic problem, it's an arthrological problem, so the joint glide will be limited as well. Pericapsular restrictions, when you try and glide the joint or move the joint, actually, you come across a harder capsular end field than you would expect. Certainly, if you can compare it to the other side, it will be harder. So you get a harder than expected capsular end field, and that's because the capsule, the restraining movement, is thicker than it normally is, and so it feels tighter. And the difference between a pathomechanical end field, the subluxation, the pathomechanical hypomobility, and the end field of a pericapsular restriction is one feels stiff and the other one feels jammed up. So it's not a bony end field, it's sort of a jammed end field that's got some liveliness to it, but it certainly isn't that dead bone to bone end field that you get. Arthritic, when the joint inflammation is what's limiting the movement, if it's kicking off spasm, which it probably will do, then you'll get a lively resistance to your movement. It'll just kick back at you suddenly. So, as I say, all three are going to show joint glides restricted, but each one will show a slightly different end field, or a significantly different end field, actually. For extra-articular restrictions, we're looking at the muscle. So if the muscle has been damaged, then you may get scarring in it with adhesions, and you get an inextensible muscle, and that's going to restrict the range. On the other end, the muscle can be hypertonic. So this tone is caused by neurophysiological problems, particularly, if not entirely, segmental facilitation. But the muscle becomes hypertonic and the tone restricts the movement. This is not like spasm, where you get a kickback at it. You either feel the movement's restricted, and often you'll feel a jammed end field, because that tight muscle now, hypertonic muscle, can act like another ligament, and it gives you an abnormal center of rotation, which can make the joint sort of feel jammed. You're going to have two centers of rotation in this case through the single bone, and that's going to jam the movement. So it can feel jammed up. The difference is, though, that the joint glide with extra-articular restrictions is normal. What it was before that restriction is what it is after that restriction occurs. So the problem is it might be a little different from the other side, simply because you've got facilitation there. But the restriction isn't, the extra-articular restriction isn't affecting the joint glide. Then we move on to hypermobility. Two types of hypermobility. One is irritable and the other one is non-irritable, or if you like, painful and not painful. With the painful irritable type, what you'll get is a normal range of motion, but at the end of that range, you'll get pain and or spasm kicking in. Now, pain and or spasm says that this isn't normal movement. So if you've got the scale of a normal range, but then you get this abnormal finding at the end of it, pain or spasm again, it means there's more movement to go. If the spasm was being kicked off by arthritis or by pain from another cause, then the range would be limited, and the spasm would kick in during the movement through the normal range. This is occurring at the end of normal range. So this tends to be hypermobility, and the tissues that have become under stretch when you move that range are touchy. They are irritable and they're painful, and they kick off the spasm sometimes. Non-irritable types is usually where it's been sort of stretched out very, very gradually, and you just have excessive physiological range. And you can feel the range increase. And usually you have a soft capsular end fill because the capsule has been stretched out. The joint glides in these cases will be normal or excessive, depending on which one we're talking about, but the joint glides will be normal or excessive. And you don't need to test them. You actually do not need to test them if you found physiological hypermobility, because those ranges must be increased. The arthrokinematic must be increased because the physiological ranges. Then we come to instability. Again, two types for us. Ligamentous instability, where the capsule or the ligaments have actually been overstretched or torn, and articular instability, where the articular surfaces have degenerated and thinned out. This is arthrosis. This is always the beginning of arthrosis. Arthrosis always begins with instability. So with ligamentous instability, when you tear a ligament, you have a unidirectional instability. For example, if I tear the valgus ligaments of the knee, it will be unstable when it's the medial ligaments of the knee rather, it will be felt to be unstable when I abduct the leg, but not when I adduct it. So these tend to be unilateral, or if the ligament's big enough, bilateral. With articular instabilities, it depends on how much of the articular surface is degenerate. So if we have a uniform degeneration of the surface where we get uniform thinning of the cartilage, so they're sort of coming together, then the instability may be omnidirectional. But it's a little rare, but it can happen. More usually though, it's multi-directional instabilities. Now, when you test a ligamentous instability, the end fill is soft capsular, provided you're not getting spasm in the vein because of the pain. But the end fill is soft capsular. With an articular instability, the end fill is normal. You get it to the end of the range, and then the normal ligament comes into play, and you get this normal end of range. So you get instability with a normal end fill with articular, and instability with a soft capsular end fill and abnormal end fill when you're looking at ligamentous. So it's a quick summation of defining each one of these motion dysfunctions. Okay, so let's look at making the diagnosis. The diagnosis of biomechanical dysfunction isn't made by the biomechanical exam. You do the biomechanical exam because you've made the diagnosis that this is a biomechanical diagnosis, not the other way around. The biomechanical examination after the diagnosis is made will refine the diagnosis. It will confirm it or deny it, but it will refine it, not make the diagnosis. So looking at an essential illness script for biomechanical dysfunction, I think this is probably about as short as you can get with this, with a couple of variations. These tend to be short duration episodic problems, so they'll come on, last 2-3 weeks and then go away again. Now, if you look at a history of this, the tendency for these episodes is to get longer and the rest period between them to get shorter. So as the thing becomes more and more unstable, then the time in pain becomes longer and the time out of pain becomes shorter. So this is actually very confirmatory of this. The intensity of the pain and the amount of referral is moderate. It's a flexion or extension impairment that dominates the picture. So while they may get pain on walking and running, sharp pain on walking and running, they may also say that if I sit for more than a half hour, my back starts to ache and it gets a bit stronger as time goes on. While they're feeling it both in flexion and extension, clearly one or the other dominates the picture. There's non-obligate functional loss. That is, they elect not to do things because they know it's going to be a problem later on, or if they do have to do it, they know that they're going to suffer for it. But they choose to not do it or to do it. There's no, I can't do this with this stuff. On range of motion, one range is painful and limited. Now, when I say one pain, if we're looking at the spine, for example, let's say extension is the painful range, then extension will be painful. but the movements that extend the facet are also going to be painful. So right side flexion, if it's the right facet that's in trouble, and one of the rotations, whichever one extends that facet, and I'm not going to get into coupling movements because we're not dealing with a normal problem anyway, so the coupling movements could be almost anything. But basically, one movement will be painful. Now, if we're looking at a peripheral joint, that one movement will also be associated with its conjunct movement as well. So, for example, if I've got a limitation of hip extension because of a jammed joint, for example, then I'm also going to have limitation in medial rotation. But in the sense of the composite movement of flexion or extension, it will be one movement. We can do a PA, and the PA, the response to the PA should be appropriate for the condition. So if I've got moderate pain, then the PA should give me a moderate response. Not a moderate pain, you know, I push on the thing and I get severe spasm and severe pain. Alternatively, what we can do is look for neurophysiological evidence of a biomechanical dysfunction. So we can go in and look at the multifidus, if we're looking in the spine, for example, and we can look for it to be hypotonic or wasted, that is soft. You can put your finger into it a lot easier at that level on that side. Or it could be hypertonic if there's enough nociception. So we're looking for neurophysiological responses that would give you an idea that there is a biomechanical dysfunction present. The outliers of this are more common outliers, which are not terribly common. The first episode is you are going to see patients where they won't have a history of this before, but they've got it now. And you can't say this is the first episode because you don't know if this is actually going to end up being episodic. This is an outlier, but it does occur. The other one is severe pain. And this often occurs on the first episode as well. For example, motor vehicle accidents. Eventually, you may well manipulate somebody's neck who's been in a motor vehicle accident to get rid of the biomechanical dysfunction that the motor vehicle accident has caused. It didn't. It triggered it. That problem was there previously. If the motor vehicle accident was damaging enough to produce that instability that allowed these jammed joints to occur, then the patient will be in severe pain for a long time. If you're getting a history, okay, that may be actually the cause of it, and maybe rather than the trigger, but you rarely get that sort of history, and it usually means a fracture anyway. So severe pain on the first episode is the other outlier. But again, it's a little unusual. Extensive referral of pain. Now, this is also part of the severe pain syndrome. There's really four things that produce referred pain or potentiate referred pain. One is the intensity of the pain. The other one is the nearness of the tissue to the spine. The depth of the tissue is a third, and how long you've had the problem is a fourth. So the more of those characteristics you've got, the more extensive the referral can be. But severe pain is a real kicker for this. So they tend to go together, as does a flexion and extension impairment, and as does, well, I haven't got it on there, obligate functional loss. So they have, when you ask them, they have trouble doing flexion and extension, but when you ask them to move flexion and extension, both are in trouble. All of this is about the severity of the pain, but if you now start thinking in these terms, first episode, or at least never had an episode before, severe pain, extensive referral, flexion and extension impairment, you are now thinking of a disc herniation rather than a biomechanical dysfunction. And your examination, when it disproves the dysfunction, the disc herniation rather, then brings you back to biomechanical dysfunction or something else. But you end up back into biomechanical as an outlier, an atypical biomechanical dysfunction from that. And there's no doubt about it, trying to differentiate between an outlier and something else that looks more like what you've got is very difficult, and you have to go through the stages of doing that. Even more difficult is when you have two outliers. and you're comparing two outliers. So it looks like it might be a disc, but in this case, for example, the straight leg raise may be negative. So you're looking at this either be a contained herniation or something else. Now, if the pain is unilateral, not bilateral, and there's no radiculopathy, the straight leg raise is negative, then you come back and shift over a biomechanical dysfunction or the outlier of an uncontained herniation. So you're trying to, what's the word I'm looking for here? You try to sort between two outliers, and this is where it does get difficult. So, differential diagnosis for this: disc herniation or protrusion without neurological effects, spondylolisthesis, certainly a unilateral type of rotary instability in the spine, or a unilateral stenosis. So it could be any of these. Having made the diagnosis of biomechanical dysfunction, though, now you can start thinking about the biomechanical examination. And I would strongly suggest that you don't try to predict what you're going to find in your biomechanical exam from what you found in your diagnostic exam. For example, extension may be painful, but the problem may be a flexion subluxation. For example, for good reasons. About half the time, taking the joint into the subluxation, the pathomechanical hypomobility, is painful. And about half the time, it's taking it out of that position, trying to move it into the hypomobile range is painful. So it doesn't help. Plus the fact the pain may actually be on the hypermobile side that's been made hypermobile by the other side being hypomobile, or above or below it. So knowing where the pain is, what movements produces the pain, doesn't talk to you about the dysfunction that you will end up treating. So don't make predictions. It's just not worth it. And it's also, it tends to frame you. So I would strongly advise you not.